Yeah, good afternoon, everyone. Welcome to today's webinar session designed to equip you with an effective examination strategy pertaining to breast cancer malignancy related drugs. So, without much delay, let me first begin with introducing our program director, Dr. Moshmi, Senior Consultant and Head, Amrita Hospital, Faridabad. Over to you, ma'am.
Good afternoon, everybody, and thank you for joining this webinar. So, this is the Amrita E-Gurukul webinar series, and we are thrilled to introduce this series, which is an online educational initiative designed specifically for the DM and the DNB students. So, building on the success of our previous Gurukuls, this program offers a structural series of engaging webinars aimed at delivering high quality clinical insights, and it is tailored to meet the unique needs of residents preparing for the exams. And this is a weekly webinar. Which is happening almost every Sunday until May, I suppose. So, this webinar series is being conducted by Amrita Hospital and Indian Cooperative Oncology Network. And each webinar will feature a presentation by an expert speaker, followed by expert comments and takeaways from examiner and moderator in the field, and followed by question and answers. So with that, we begin our today's program, and I would like to introduce our moderator, who is a distinguished person, Dr. Vineet Gupta. He is the additional director and unit head in the Department of Medical Oncology at Fortis Hospital, New Delhi. So welcome, Dr. Vineet Gupta, and over to you.
Yeah, thank you, Dr. Mashmi. And let me welcome everybody once again to today's session. And first of all, let me introduce the mentor for this session. So subject mentor is Dr. Vidit Kapoor. He is Assistant Professor in Medical Oncology at Amrita Institute of Medical Sciences at Faridabad. And for today, the presenter is Dr. Barnini Ghosh. She is Consultant Medical Oncology at Ruby General Hospital, Kolkata. So I think today's topic, so I remember when I was doing my DM, my HOD Lalit Kumar sir always used to say same thing to us every time on routes that, see, you guys are medical oncologists. The most important thing which you guys have are the drugs. And if you guys don't know how to use the drugs, then you are useless. So that's what he always said, ki you should strive to know every fine detail of these drugs so that, you can deliver that level or that better level of care. So I think in this series, you've had previous session on, for example, lung cancer and other things. And it is good idea to have this session on drugs used in breast cancer, because in clinical practice, it is the most common number one cancer overall in our country. And this is the kind of patient you will see most commonly. And it is very, very important that all, students as well as practitioners know fine details of every drug which they are using to deliver the best quality of care they can deliver. So let me just introduce our speaker again, Dr. Barnini Ghosh. And madam, you can take over and start the presentation.
So are the slides visible?
Yes, ma'am.
Yes.
Okay. So good afternoon, everyone. First, I want to thank the organizers for giving me this opportunity. And I also want to express my gratitude towards Dr. Vineet Gupta sir, Dr. Senthil Rajappa sir, and Dr. Vidit Kapoor sir for guiding me throughout the preparation period for this presentation. So without any further delay, I will start today's presentation, which is drugs in breast cancer. So here I have given a brief overview of the drugs which I'm going to discuss today. One is the anthracycline-based regimens. The taxanes I will not discuss in details as they have been covered in the other systems. Then I will discuss eribulin, sacituzumab, govitecan, PARP inhibitors, HER2-directed therapies, hormonal therapies, CDK4/6 inhibitors, and lastly the PIK3CA, AKT, and mTOR inhibitors. So the drugs used in breast cancer malignancies are used mainly in these three settings: neoadjuvant, adjuvant, and palliative settings. So first I will begin with the HER2 negative disease. So here I have shown some of the regimens which are used in the neoadjuvant setting in HER2 negative breast cancer, which may be either hormone receptor positive or triple negative breast cancer. So earlier, the drugs which were used were the CMF regimen by Bonadonna and the TAC regimen, which is a combination of taxanes, anthracyclines, and cyclophosphamide together. But nowadays, these regimens are no longer used. We commonly use this dose-dense regimen consisting of doxorubicin and cyclophosphamide for 4 cycles, which is followed by taxanes, that is weekly paclitaxel or 2-weekly paclitaxel. Either of this is used for another 4 cycles. Alternatively, this AC regimen may be used every 3 weeks along with 3 weekly taxanes, which is docetaxel. So we have another option of replacing the doxorubicin with another anthracycline, which is epirubicin. And in patients in whom anthracycline should be avoided, like particularly the elderly patients with poor PS or with poor cardiac function, in such situations, a combination of docetaxel and cyclophosphamide may be used. So I just want to say that what is this dose-dense AC regimen that we are talking about here? So dose density means the increase in dose intensity, which is basically the total dose per unit time. How this dose intensity is increased by reducing the interval between 2 particular chemocycles. So here we see that instead of every 3 weeks, here the cycle duration is every 2 weeks. So this is the dose dense regimen, and the advantages are improved outcomes in the curative setting as well as the shorter duration of chemotherapy. So next I will discuss the drugs in the adjuvant setting for HER2 negative disease. Those regimens which I have discussed in NACT, those regimens are already there, and additionally there are some other regimens, like in case of TNBC particularly, if after completing NACT the patient undergoes surgery and there is a presence of residual disease upon surgery, then adjuvant capecitabine may be used. For germline BRCA mutation patients, with either germline BRCA1 or 2 mutation, there is the option of using adjuvant olaparib for 1 year for patients at high risk of recurrence. So who are the patients at high risk of recurrence? These are the patients who have received either neoadjuvant chemotherapy or adjuvant chemotherapy. See, here I have shown these 4 sets of patients. They may be either hormone receptor positive or they may be triple negative. For hormone receptor positive cases, those patients after neoadjuvant therapy who have not achieved pathological complete response and whose CPS EG score is more than equal to 3 may be considered for adjuvant olaparib. So what is the CPS EG score? C stands for pre-treatment clinical stage. PS stands for post-treatment pathological stage, E for estrogen receptor status, and G for grade. So there is one online calculator at the MD Anderson website, which can be used for calculation of this score. For hormone receptor patients, again, hormone receptor positive patients, if after adjuvant therapy, 4 or more positive lymph nodes are there. So this is also another indication of giving adjuvant olaparib. And while for triple negative patients, those who have not achieved PathCR after NACT, or those who have received adjuvant chemotherapy but with pathological T2 or N1 disease, they may be selected for adjuvant olaparib for 1 year duration. Now coming to the option which is only for hormone receptor positive patients and those who are at high risk of recurrence. So the 2 drugs, the CDK4/6 inhibitors, abemaciclib and ribociclib, are available for this indication. They are given along with endocrine therapy in high risk patients. So how do we determine these high risk patients? So these high risk patients are for abemaciclib, node positive early breast cancer, that is either 4 or more pathological axillary lymph node positive or 1 to 3 pathological axillary lymph node positive with either grade 3 tumor or a tumor size more than equal to 5 centimeter. For ribociclib, it may be once again given for node positive patients, or it may be given in node negative patients as well, provided that the tumor size is more than 5 centimeter or the tumor size is between 2 to 5 centimeter with either grade 3 or grade 2 along with high Ki67, that is more than equal to 20%. So now we will discuss the drugs individually one by one. We will start with anthracyclines. So here you can see I have given a list of the drugs which are included in anthracyclines. Of them, only 2 are used in breast cancer, that is doxorubicin and epirubicin. So what are these anthracyclines? These are a type of anti-tumor antibiotics that come from certain types of streptomyces bacteria. What is their mechanism of action? These are topoisomerase 2 inhibitors. So first we will see what is the normal function of these topoisomerase 2 inhibitors. These enzymes are critical for unwinding of the DNA for replication and synthesis. So what happens when the topoisomerase 2 inhibitors are given? These topoisomerase 2 inhibitors attach to the DNA and enzyme binding site, forming a stable complex. How the topoisomerase actually unwinds DNA by cutting and religating the DNA strands. But here we see that due to stabilization of this enzyme DNA complex, this strand is broken, but it cannot be religated. So this leads to replication failure, and which leads to cell cycle arrest and ultimately cell death. So the topoisomerase 1 also, I will just say here that topoisomerase 1 also has functions similar to topoisomerase 2. The only difference being that topoisomerase 2 cuts and religates double strands of DNA, while topoisomerase 1 cuts and religates single strands of DNA. So here these anthracyclines are topoisomerase 2 inhibitors. So their major mechanism of resistance is drug efflux, and these drugs are mainly cleared by biliary excretion. Hence, if bilirubin is elevated, dose reduction is necessary. So here you can see I put a picture of this doxorubicin. So it may be available either as a liquid form or it may be available as a powder form, which needs to be reconstituted with normal saline. And it is red in color. The name rubicin indicates that it is red in color. Now, coming to the side effects. The side effects I have highlighted here, the most important side effects of this drug. One is the myelosuppression, which can be dose limiting. Second, and the most important, is cardiotoxicity. It is dose dependent and cumulative. Mainly, we see it in the form of cardiomyopathy. However, there can be some arrhythmias. So to avoid this cardiotoxicity, lifetime cumulative dose limit has been recommended, which is 450 to 550 mg per meter square. So what happens is that beyond a cumulative dose of 300 mg per meter square, the risk of cardiotoxicity significantly increases up to as high as 20% beyond 550 mg per meter square. Hence, this dose limit has been recommended. It is a potent vesicant, that is, extravasation may lead to tissue necrosis and chemical thrombophlebitis at the injection site. There may be risk of secondary leukemias, usually with a latency period of 1 to 3 years. However, it may also occur 5 to 10 years later. Now, the other side effects which are common for most of the chemotherapy drugs, these are nausea, vomiting, mucositis, alopecia. There may be reddish discoloration of urine because the drug is red in color. There may be a radiation recall phenomenon. So what is this? That in previously irradiated patients, when doxorubicin is administered, it leads to an acute inflammatory response at the previously irradiated sites. This phenomenon is called the radiation recall phenomenon. Additionally, there may be photosensitivity, nail hyperpigmentation, etc. So the dose, we see that for the dose dense AC as well as the 3-weekly AC, the dose of doxorubicin remains the same. That is 60 mg per meter square of doxorubicin along with 600 mg per meter square of cyclophosphamide, which is given either every 21 days or in the dose dense regimen, which is given every 14 days. And this is usually given for 4 cycles, which is followed by 4 cycles of taxanes. Now, drug interactions with trastuzumab, there is increased risk of cardiotoxicity. And since we have seen that this drug is metabolized in the liver, phenobarbital, phenytoin, that is the inducers of the hepatic macrosomal enzyme systems, can also lead to increased plasma clearance of this drug. Now, coming to the risk factors for cardiotoxicity. So who are the patients who are at high risk of cardiotoxicity from anthracyclines? Those aged more than 65 years, those who have a previous history of heart disease or hypertension, who have previously received radiation to the chest or mediastinum, who have prior history of anthracycline use or other cardiotoxins, where the drug is co-administered with paclitaxel, cyclophosphamide, or trastuzumab. It has been observed that doxorubicin followed by paclitaxel is less cardiotoxic than the reverse sequence. So what we have to do as a precaution, we have to assess the baseline cardiac function of the patient by ECG, echocardiography, and sometimes by radionuclide scan if indicated. And later we have to monitor the cardiac functions of the patient by using the same investigations. So the cardiotoxicity of the anthracyclines are of two types, either acute cardiotoxicity or delayed cardiotoxicity. So acute cardiotoxicity occurs within days or during an anthracycline infusion. It is usually reversible. There can be tachycardia, hypotension, ECG changes, or arrhythmia. This may be reduced by slowing the infusion rates. So doxorubicin is commonly administered by an IV infusion over 10 minutes. But if we can slow the infusion rate somewhat, then it may lower the risk of cardiotoxicity. However, it must be remembered that the reconstituted solution is to be used within 1 hour and it should be protected from light. Now, chronic and delayed cardiotoxicity from anthracyclines, it is more common, usually occurs within 2 to 3 months of treatment completion or even later. It is more severe and irreversible. There is myocardiocite damage in this case. Prevention, cardioprotector drug is available, which is dexrazoxane. It reduces the risk, but robust data regarding this is unavailable. And this is one of the FDA-approved indications of dexrazoxane to reduce the risk of cardiotoxicity with anthracyclines. Also, it is FDA-approved for the treatment of extravasation injury caused by anthracyclines. And the other possible approaches to lower the risk of cardiotoxicity are slowing of the infusion rates, as I said, or use of liposomal preparation. Now, coming to the drug epirubicin, it is basically an epimer of doxorubicin with increased lipophilicity. It has similar toxicity profile to doxorubicin. It is less cardiotoxic and better tolerated. So I have shown the vials here. It is also available either as a red liquid or as a red powder, which needs to be reconstituted with normal saline. The commonly available vial strengths of both doxorubicin and epirubicin are 50 mg and 10 mg, and sometimes a 20 mg vial of doxorubicin may also be available. So the equivalent dose of epirubicin for 60 mg of doxorubicin is 90 mg. So if we change the regimen from AC to EC, we can see that the cyclophosphamide dose remains the same, but the epirubicin dose changes to 90 mg per meter square. And it may be given every 3 weeks or every 14 days if the dose dense regimen is being used. Now coming to the next drug, that is cyclophosphamide. So this is an alkylating agent and it is a cell cycle non-specific drug. So what happens is that when the cyclophosphamide enters the body, it is metabolized by the hepatic macrosomal enzyme system, that is the CYP450. And in a series of steps, it gets converted to its active form, phosphoramide mustard. Another metabolite is generated, which is acrolein, and this metabolite is responsible for the hemorrhagic cystitis caused by cyclophosphamide. So this phosphoramide mustard is actually the reactive agent which results in alkylation of the cellular macromolecules like DNA, forming covalent bonds, and it leads to the formation of interstrand cross-links between the DNA, and this leads to inhibition of DNA synthesis. So this causes ultimately cell cycle arrest and cell death. Now, cyclophosphamide is available as a white powder. It needs to be reconstituted with normal saline. The commonly available vial strengths are 500 mg, 1 gram, and even 200 mg. So the common side effects of cyclophosphamide are dose-limiting myelosuppression, alopecia, nausea, vomiting, anorexia, and nail discoloration. And the less common side effects are diarrhea, mucositis, and hemorrhagic cystitis. As I have already said that for this toxicity, the acrolein metabolite is responsible. There may be hematuria, painful urination, etc. Now, drug interactions, as I have already said previously, that with doxorubicin, there is increased risk of cardiotoxicity. The metabolism is increased by drugs stimulating the hepatic macrosomal enzyme system, as it is metabolized by that system. Also, it in turn alters the plasma level of other drugs which are metabolized in the liver. So I'll see what I will be repeatedly discussing regarding drug interactions is this: the inducers and inhibitors of the hepatic microsomal enzyme system. So before moving to the next slide, I will just like to say that you have to remember some common names of hepatic microsomal enzyme system inducers like phenobarbital, phenytoin, rifampicin, and some inhibitors like protease inhibitors, antifungal azoles, etc. So these you have to remember because I have not mentioned them separately in every slide, but I have just provided the basic concept. So next I'll move on to the taxanes. The two taxanes which are used in breast cancer are paclitaxel and docetaxel. However, I will not discuss these drugs in details today as they have been already covered in the other systems. So one important trial which I want to discuss here is the E1199 study, which was the 10-year follow-up trial which evaluated taxanes and their schedules in operable breast cancer. It was a phase 3 trial. Here we see that the patients who have received 4 cycles of adjuvant AC were randomized to receive either weekly paclitaxel or 3-weekly paclitaxel, or weekly docetaxel or 3-weekly docetaxel. The 10-year follow-up data showed similar DFS and OS for both weekly paclitaxel and 3-weekly docetaxel, and this was much better compared to 3-weekly paclitaxel. However, the toxicity was more in case of 3-weekly docetaxel than weekly paclitaxel. And in triple negative patients, weekly paclitaxel significantly improved the DFS and OS over all other regimens. For hormone receptor positive disease, the outcomes were poorest for obese patients and black patients, independent of the obesity status. So this is how the weekly paclitaxel came into the regimens that I have discussed previously. And if chemotherapy is given every 3 weeks, then docetaxel is preferred instead of 3-weekly paclitaxel. Now coming to the TNBC only regimens. So adjuvant capecitabine, as I was saying, that for a patient of TNBC who has completed preoperative chemotherapy and having residual disease on surgery, adjuvant capecitabine is an option. The evidence is provided by the Createx trial. Here the dose of capecitabine is 1000 to 1250 mg per meter square, given twice daily for days 1 to 14 with a 7 days gap, and thus cycled every 21 days. The capecitabine is to be taken 30 minutes after a meal. I have not discussed capecitabine in details here as it has been extensively covered in the GI system. Now there is another perioperative regimen, which is the Keynote 522 regimen, where pembrolizumab is combined along with chemotherapy. So preoperatively, we give pembrolizumab 200 mg every 3 weeks in combination with weekly paclitaxel and either weekly or 3-weekly carboplatin for a total of 4 cycles. Thereafter, we again give pembrolizumab in combination with doxorubicin or epirubicin and cyclophosphamide. After that, the patient is operated, and in the adjuvant setting, maintenance pembrolizumab is given for another 9 cycles. There is also the option of paclitaxel and carboplatin in TNBC that I had mentioned previously. Paclitaxel is given weekly and carboplatin may be given either weekly or 3-weekly. So coming to the drugs used in metastatic TNBC. So we can see that in the first line setting, there is the option of using pembrolizumab, which is an immunotherapy. So we have to first assess the PD-L1 score. If the combined positive score is more than equal to 10, then regardless of the germline BRCA mutation status, we may give pembrolizumab along with chemotherapy. The chemotherapy given is carboplatin along with either albumin-bound paclitaxel or gemcitabine. If PD-L1 is negative and there is germline BRCA mutation, then we may give either PARP inhibitors like olaparib or talazoparib, or we may use platinum agents like cisplatin or carboplatin, since we know that BRCA mutant patients are platinum sensitive. Now, if both PD-L1 and germline BRCA mutations are negative, we have the option of giving systemic chemotherapy. In the second line setting, once again, if germline BRCA mutation is positive, we may either give olaparib or talazoparib, that is PARP inhibitors. There is another drug which is approved in this settings, that is sacituzumab govitecan, which I will discuss later. And there is also the option of giving systemic chemotherapy. If the patient is HER2 low or ultra low, then we may even give trastuzumab deruxtecan. Third line and beyond, the option of systemic therapy is already there. And along with that, we may also give biomarker-directed therapy. So what are the systemic chemotherapy regimens? We see that single agent regimens are preferred in the metastatic setting because of their less toxicity and almost equivalent survival benefit compared to multi-agent chemotherapy. However, multi-agent chemotherapy is to be considered in select patients with high tumor burden, rapidly progressing disease, and visceral crisis. So the preferred regimens used for systemic chemotherapy are anthracyclines, taxanes, antimetabolites like capecitabine and gemcitabine, microtubule inhibitors like vinorelbine, eribulin. Also, drugs like cyclophosphamide or ixabepilone may be used. And the regimens, as we have seen, paclitaxel, carboplatin, gemcitabine-based regimens, and AC, EC, CMF, all these regimens may be used. So this is the slide on the biomarker-directed therapy. So if there is a germline BRCA mutation, we may use olaparib or talazoparib. If there is somatic BRCA mutation, we may use olaparib. For germline PAL-B2 mutations, olaparib may be used for NTRK fusions, larotrectinib, entrectinib, repotrectinib. For MSI high or deficient MMR, pembrolizumab or dostarlimab may be used. For tumors with high tumor mutational burden, pembrolizumab may be used. For RET fusion, selpercatinib, and for FGFR1 to 3 fusions or mutations, we may use erdafitinib. So coming to the next class of drugs, PARP inhibitors. What is this PARP? It stands for poly-ADP ribose polymerase, which are the enzymes which are responsible for repairing the single-stranded DNA breaks in the cell. Now, if the this PARP enzyme is inhibited, these SS breaks are not repaired and they are converted to double-stranded breaks. Now we know that in a patient with baseline germline BRCA mutation or HRR deficiency, the double-stranded DNA break repairing mechanism is already hampered. So along with that, this single-stranded breaks, this together combined is lethal for the cell and leads to apoptosis. This is the concept of synthetic lethality that we say for PARP inhibitors. Here I have given two pictures of olaparib and talazoparib. So these olaparib tablets, as we can see, are available in 100 mg and 150 mg strengths. And the talazoparib tablets are available either as 1 mg tablets or as 0.25 mg tablets. So here I have discussed these two drugs together. We can see that both the drugs are indicated in the metastatic setting. Also, as I have previously discussed, that there is role of olaparib in the adjuvant setting for HER2 negative patients who are at high risk of recurrence. So the dose of olaparib is 300 mg twice daily. That of talazoparib is 1 mg OD. Now, coming to the toxicities which are common to both the drugs, as we can see, are myelosuppression, fatigue, nausea, vomiting, and the risk of secondary MDS or AML. Also, both the drugs may cause abdominal pain and diarrhea. Additionally, olaparib has some risk of pneumonitis, arthralgia, myalgia, and talazoparib may lead to elevated liver transaminases. Now, coming to drug interactions, olaparib, the plasma levels of olaparib are influenced by CYP3A4 inhibitors and inducers. As I was saying previously, the inducers are drugs like phenobarbital, phenytoin, and rifampicin, and the inhibitors are the drugs like protease inhibitor and antifungal azoles. Since the drug is metabolized by the hepatic microsomal enzyme systems, so these drugs may alter the plasma levels of olaparib. Now, the next drug is eribulin. It is approved in the setting of metastatic TNBC. So what is it? It is a synthetic analog of helicondrin B, which is obtained from marine sponge Helicondria species. This is a picture of that sponge. And the mechanism of action is, it is a microtubule inhibitor, and thus it is cell cycle specific for the G2M phase. So how does eribulin act? Eribulin inhibits microtubule growth, and thus it leads to formation of non-productive tubulin aggregates. Now these tubulin aggregates disrupt the mitotic spindle formation during cell division, and thus the cell division is arrested, which leads ultimately to cell death. This drug has shown activity in the taxane-resistant setting. And eribulin is available as a clear colorless liquid. It is available in 1 mg vials. Now, the side effects of this drug, most commonly myelosuppression. It may cause dose-limiting neutropenia. Then there is fatigue, anorexia, nausea, vomiting, dyspepsia, mucositis, and diarrhea, which is just like other chemotherapy drugs. Additionally, it may cause peripheral neuropathy. Also, there is a rare complication, that is QTC prolongation. Hence, it is to be avoided with drugs prolonging the QTC interval. Now, the next drug is sacituzumab govitecan. This is an antibody drug conjugate. So I'll just explain from the name of this drug, what are the components. See, this for MAB stands for monoclonal antibody and ZU for humanized. So it is a humanized monoclonal antibody. And this govitecan is the cytotoxic payload. From the suffix tecan, you can guess that this is a topoisomerase 1 inhibitor. So this monoclonal antibody is directed against the TROP2 receptors, which are expressed on the breast cancer cells. So I'll now explain the mechanism of action of this drug. So first, I will explain the common mechanism of action, which is common for all antibody drug conjugates. That is, when an antibody drug conjugate binds to its particular receptor, this entire receptor drug complex is internalized within the cell. Then there is intracellular lysosomal degradation with release of the cytotoxic payload within the cell. In case of this drug, the active component of the cytotoxic payload is the SN38, which is a topoisomerase 1 inhibitor. And then this drug causes DNA damage. The extracellular drug release also occurs, which leads to penetration of the drugs into the neighboring cells and also causes death of the neighboring cells, even if they do not express the TROP2 receptors. So this is called the bystander effect. And also there is another additional mechanism, that is ADCC, antibody-dependent cell-mediated cytotoxicity. So what happens whenever a monoclonal antibody binds to the surface of the cancer cell, this FC region of the antibody is recognized by the FC receptors on the immune effector cells like the NK cells. This leads to activation of the NK cells and the release of perforin and granzymes, which results in ultimately cell damage. So topoisomerase 1 inhibitor mechanism, I'll just say briefly, as I have already said in the previous slide, that these topoisomerases are enzymes which are responsible for unwinding of the DNA for replication and synthesis. So what do? They cut and religate the DNA strands and enable DNA synthesis to take place. Now, topoisomerase 1 means it cuts a single strand of DNA and religates it. So when this inhibitor is given, what it does is it stabilizes the enzyme DNA complex and it prevents replication. Thus, it leads to cell cycle arrest and cell death. So this is a picture of the sacituzumab govitecan vials. It is available as a lyophilized powder, which needs to be reconstituted with normal saline, and the vial strengths available are 180 mg and 200 mg. The dose is 10 mg per kg IV on days 1 and 8 of a 21-day cycle. So among the side effects, the easy way to remember is that this is a monoclonal antibody. So obviously there will be some degree of infusion reactions. Now for the cytotoxic payload part, it will be just similar to the side effects of cytotoxic chemotherapy, like nausea, vomiting, alopecia, and myelosuppression. Since it is a topoisomerase 1 inhibitor, so another toxicity is there, which is severe diarrhea. It is similar to that of irinotecan. So patients may suffer from severe diarrhea. So as pre-medications, what we have to give in order to prevent the infusion reactions and this diarrhea, we may give injection Avil, that is phenyramine maleate, as a pre-medication. And for diarrhea also, we can give injection atropine to prevent this drug-induced diarrhea. Now, drug interactions, we see that this drug is metabolized by the UGT1A1 enzyme in the liver. Hence, the inducers and inhibitors of this enzyme alters the plasma levels of these drugs. And also there is increased toxicity in Gilbert syndrome, where there is decreased activity of the UGT1A1 enzyme. Now I will come to the HER2-directed therapies. So before beginning that, I will just show this picture that these are the 4 receptors in the human epidermal receptor network. One is the HER1 or EGFR. Then the second is HER2, then HER3, and lastly HER4. Now HER2 and three are not fully competent, but their functions are highly complementary to each other. So in this picture, I have shown all the mechanisms of action of all the HER2-directed therapies together. So here is the structure of the antibody drug conjugate. Here the trastuzumab deruxtecan is actually shown. So what is there? There is one monoclonal antibody, and to that the cytotoxic payload, that is the chemotherapy drug, is linked along with a cleavable linker. So one by one, I'll just explain the mechanism of actions of these drugs. So first I'll begin with trastuzumab, pertuzumab, and margetuximab. So these are anti-HER2 monoclonal antibodies which attach to the HER2 receptors and inhibit the downstream signaling of these receptors. So we have to know that pertuzumab binds to a different epitope of HER2 than trastuzumab. The next drugs are the tyrosine kinase inhibitors, the lapatinib, neratinib, and tucatinib. So these drugs inhibit the tyrosine kinase moiety of these receptors and thus inhibit the downstream signaling of these drugs. Next, there are two antibody drug conjugates, that is TDM1 and trastuzumab deruxtecan. So we can see once again from the name deruxtecan, the suffix tecan indicates that here the payload is a topoisomerase 1 inhibitor. And for TDM1, that is adotrastuzumab emtansine, there's a simple way to remember. So if you just look at this portion DM1, so if we write the letter 1 as a Roman 1, then this last two words, that is MI, it indicates that the payload is a microtubule inhibitor. So these are some simple ways to remember what are the payloads for which drugs. Now, the antibody drug conjugate, the mechanism, as I have previously explained, there is internalization of this drug and receptor complex, followed by lysosomal degradation and intracellular release of the cytotoxic payload. And also, as we can see that all the drugs here are monoclonal antibodies. So they will all have this effect of ADCC, that is antibody-dependent cell-mediated cytotoxicity. So once again, when these monoclonal antibodies bind to the receptors, this Fc region is recognized by the Fc receptor on the immune effector cells like the NK cells, which leads to their activation and helps in cell killing. So here in a tabular form, I have given all the mechanisms of actions of the drugs. So I have discussed all these basically in the previous slide. So here what I want to mention is that among the TKIs, only tucatinib is selective for HER2 and rest of the TKIs like lapatinib and neratinib inhibit the tyrosine kinase moiety of HER2 as well as the other HER receptors. Now coming to the regimens once again, which are used in HER2 positive breast cancer. In the curative setting, that is the preoperative or the adjuvant setting, the regimens which are commonly used are TCH, that is docetaxel, carboplatin, and trastuzumab, plus minus pertuzumab. So pertuzumab is particularly indicated where there is locally advanced disease and particularly node-positive disease. And in elderly patients who have poor PS or not a very high tumor burden, in such cases, paclitaxel and trastuzumab may be used. The other regimens which may be used in some centers, anthracyclines are also used, though there is increased risk of cardiotoxicity. Hence, the most recommended regimens do not have anthracyclines, as you can see. But in some centers also, they give anthracycline-based regimen, that is AC or EC, and followed by trastuzumab or pertuzumab along with taxane. Trastuzumab plus minus pertuzumab along with the taxanes. Another regimen is docetaxel, cyclophosphamide, and trastuzumab. Now, the drugs which are approved only in the adjuvant setting. So, if a patient receives pre-operative HER2-directed therapy along with chemotherapy, and there is residual disease after surgery, the recommended drug at this moment is adotrastuzumab emtansine. However, in patients who cannot afford this drug or it has to be discontinued for some toxicity, then trastuzumab plus minus pertuzumab is given to complete a total of 1 year of therapy. Now, what is the indication for adding pertuzumab in the adjuvant setting? It is for patients who were initially node positive at presentation. For them, trastuzumab is recommended to be added in the adjuvant setting. Now, if there is no residual disease after preoperative therapy, and also if there is no preoperative therapy, in such cases, trastuzumab plus minus pertuzumab may be used to complete a total of 1 year. Another option in the adjuvant setting is the TKI niratinib. It is given for 1 year duration. So coming to the drugs in the metastatic setting for HER2 positive disease, in the first line, pertuzumab plus trastuzumab is recommended along with a taxane, either docetaxel or paclitaxel. In the second line setting, trastuzumab deruxtecan is recommended. Third line setting, tucatinib, trastuzumab, and capecitabine. And also the drug TDM1 is there. Fourth line and beyond, we may use other regimens like lapatinib, capecitabine, margetuximab, or trastuzumab in combination with various chemotherapy agents, etc. So in this slide, I have put together the different available formulations of some of the HER2-directed drugs. So we see that trastuzumab is available as a lyophilized powder to be reconstituted with normal saline. The commonly available vial strengths are 440 mg and 150 mg, and some companies also manufacture a 375 mg vial. Pertuzumab is available as a clear transparent liquid with a vial strength of 420 mg. Margetuximab is also available as a clear transparent liquid with a vial strength of 250 mg. Now, in HER2, this is the trastuzumab deruxtecan. It is also available as a lyophilized powder for reconstitution with normal saline, and it is available in a vial strength of 100 mg. Now, these two are the TDM1, that is adotrastuzumab emtansine vials. And so this is also a lyophilized powder which needs to be reconstituted with normal saline, and these are available in vial strengths of 160 mg and 100 mg. And now the original drug was the Kadcyla, and this Ujvira has recently come into the market. This is a more cost-effective option because it is a biosimilar of TDM1. Now, I have again put these drugs in a tabular form, the 3 monoclonal antibodies. As we have already discussed, they are indicated in the metastatic setting, and also trastuzumab and pertuzumab in the neoadjuvant and adjuvant setting. So I'll straight away move on to the dose. Trastuzumab has one 3-weekly dose and one weekly dose. So 3-weekly, when it is given, the loading dose is 8 mg per kg, followed by a maintenance dose of 6 mg per kg every 3 weeks. And when it is given weekly, the loading dose is 4 mg per kg, followed by a maintenance dose of 2 mg per kg weekly. Now, for pertuzumab, the loading dose is 840 mg, followed by a maintenance dose of 420 mg every 3 weeks. For margetuximab, the dose is 15 mg per kg IV every 3 weeks. So how to remember the toxicities? So as I have already said, this is a monoclonal antibody. So the common toxicities for all three are infusion reactions. Then being HER2-directed agents, these drugs have the risk of cardiotoxicity. Additionally, trastuzumab can cause some degree of pneumonitis. Pertuzumab is one of the notable toxicities of pertuzumab, which I have highlighted here, is diarrhea, which you have to remember. It may be dose limiting. And for margetuximab, there is some degree of myelosuppression with anemia and neutropenia, and also some mild GI toxicities like nausea, vomiting, diarrhea, and it also may cause some degree of pneumonitis. So the antibody drug conjugates TDM1 and TDXT. The settings I have already discussed. Now, what I want to say here additionally is that trastuzumab deruxtecan is also indicated for HER2 low and ultra low settings. So what is this HER2 low setting? If IHC for HER2 new is 2+ and FISH is negative, or the IHC for HER2 new is 1+, then it is a HER2 low disease. What is HER2 ultra low? When there is incomplete and faint membrane staining in less than equal to 10% of the tumor cells, then it is called HER2 ultra low. So the dose of these drugs, TDM1 is given at a dose of 3.6 mg per kg every 3 weeks, and TDXT is given at a dose of 5.4 mg per kg every 3 weeks. So why I have written all these drugs together is so that you can compare and read, and most of the toxicities, as you can see, are same. Like here also there is infusion reaction, there is cardiotoxicity, there is myelosuppression due to the cytotoxic payload component, and there is also hepatotoxicity, because being the cytotoxic cytotoxic payload for TDM1 being a microtubule inhibitor, it has some toxicity similar to that of taxanes, like this hepatotoxicity, peripheral neuropathy, etc. And it also may cause some degree of pneumonitis. And for TDXD, see that the toxicity will be similar to that of irinotecan, as I have said. There will be myelosuppression with anemia and neutropenia, and then mild GI toxicities like nausea, vomiting, and diarrhea. And there is also a notable risk of pneumonitis with trastuzumab deruxtecan. Now, coming to this novel formulation, that is Phesgo. What is this? This is a fixed dose subcutaneous formulation of trastuzumab along with pertuzumab. And hyaluronidase is given along with it for better subcutaneous penetration of the drug. So what are the indications of this Phesgo? As we can see that it is FDA approved for all the same indications as pertuzumab. Now, it is given subcutaneously, mainly in the thighs. I have already mentioned there are 2 vial strengths which are available for the loading dose. We give this vial. This is containing 1200 mg of pertuzumab and 600 mg of trastuzumab. And for the maintenance dose, we give this 10 ml vial, which consists of 600 mg of pertuzumab and 600 mg of trastuzumab. And Phesgo is administered every 3 weeks. So what are the boxed warning for these drugs? So once again, there is a risk of cardiomyopathy and pulmonary toxicity like pneumonitis or ARDS, and these drugs may also cause embryo-fetal toxicity. What are the advantages of this formulation? Reconstitution or dilution is not required. No dose calculation is required. It has a flat dose. IV cannulation is not needed. It can be given subcutaneously, which is very convenient and saves a lot of time, but it does not save the cost, as this is a very costly formulation. So next I'll discuss the tyrosine kinase inhibitors, that is the lapatinib, neratinib, and tucatinib. And I have already discussed the indications previously. Now with the dose, so lapatinib along with capecitabine is given at a dose of 1250 mg orally daily without food. Neratinib dose is 240 mg OD with food. For the adjuvant setting, the duration is 1 year. Tucatinib is given at a dose of 300 mg BD with or without food. So since these are TKIs, so what are the common toxicities of TKIs that we have read? That is diarrhea, rash, and some degree of nausea, vomiting. So you'll find all these toxicities here. Most notable is the diarrhea, and the diarrhea is most notorious for neratinib. So it is the most common adverse event, 95%. It is dose limiting, and 40% of the cases have grade 3 diarrhea. Also for lapatinib also, it is the most common toxicity, 65% cases, and grade 3 toxicity is like grade 3 diarrhea is seen in 40% of the cases. It can be dose limiting. Same also with tucatinib. Same with the rash, and the rash is common side effect of all these 3 drugs. Additionally, these 3 drugs may cause hepatotoxicity. Now, lapatinib also causes some degree of cardiotoxicity and myelosuppression, most commonly anemia. And neratinib and tucatinib also has the potential of causing some arthralgia, myalgia. So what I want to say about neratinib here is, since diarrhea is seen in almost 95% of the cases, and with 40% cases having grade 3 diarrhea, for this reason, it is not a particularly popular drug in the adjuvant setting, since the cost of the drug is also high and the patient also suffers significantly due to diarrhea. So it is not a very popular option in the adjuvant setting. Coming to the hormonal therapies, in this slide, I have shown how the adjuvant hormonal therapies have evolved over time. So the initial trials on adjuvant hormonal therapy compared tamoxifen to aromatase inhibitor. Now later came the initial and sequencing trials, that is either tamoxifen followed by aromatase inhibitor or aromatase inhibitor followed by tamoxifen. Then came the switching trials, that is 2 to 3 years of prior tamoxifen, followed by switching to aromatase inhibitor. And lastly, the trials explored the extended duration of adjuvant hormonal therapy after 5 years of hormonal treatment. So in the adjuvant setting, when we give hormonal therapy, we basically look at the menopausal status of the patient. If the patient is premenopausal, then tamoxifen may be given plus minus ovarian suppression. However, we have to remember that on the basis of the soft and text trials, if such premenopausal patients are at high risk of recurrence, that is having node positive disease, etc., then aromatase inhibitor is preferred based on superior outcomes along with ovarian suppression or ablation. Now, after continuing 5 years of therapy, we may consider continuing tamoxifen for patients who were already receiving tamoxifen for additional 5 years based on the results of the ATLAS and the ATOM trials. We may consider switching to aromatase inhibitors if the patient undergoes menopause during this period, or if we were giving if we were giving aromatase inhibitors from the beginning, then we may consider additional 3 to 5 years of aromatase inhibitors, as extending aromatase inhibitor therapy has shown benefit, particularly for the node positive patients. So for postmenopausal patients, once again, aromatase inhibitors have shown superior outcomes compared to tamoxifen. Also, there is the option of initially continuing with tamoxifen and later switching over to aromatase inhibitor therapy. So if tamoxifen is given from the beginning, it may be continued for 10 years, as I have said, based on the results of the ATLAS and the ATOM trials. And for aromatase inhibitors, the duration of therapy may be extended to 7 or 10 years, particularly if the patients are node positive, as it has shown some survival benefit in this group. Now, next, I'll move on to the metastatic setting. So for the metastatic setting in hormone receptor positive cases, what we first look at is whether the patient is suffering from visceral crisis or not. If the patient does not suffer from visceral crisis, then we shall consider upfront hormonal therapy. And the recommended regimens here are aromatase inhibitors combined with CDK4/6 inhibitors. Now, if there has been disease progression on adjuvant endocrine therapy or relapse within 12 months of adjuvant endocrine therapy, that is, the patient was not an upfront metastatic case but was receiving adjuvant endocrine therapy, then in such cases, we will go for fulvestrant with a CDK4/6 inhibitor. Now, coming to the second line therapy, if an aromatase inhibitor or tamoxifen has been used in the first line setting, then in the second line setting, we may consider fulvestrant along with a CDK4/6 inhibitor, provided that CDK4/6 inhibitor has not been previously used. We may also combine everolimus with exemestane, and we may also go for these marker-directed therapies. That is, in case of PIK3CA activating mutations, we may go for alpelisib and fulvestrant. For PIK3CA or AKT1 activating mutations or PTEN alterations, we have the option of capivasertib plus fulvestrant. And for ESR1 mutant patients, we have the option of giving elacestrant. So for triple positive disease, that is HER2 positive as well as hormone receptor positive, we will have to give hormonal therapy along with a HER2-directed therapy. Now, what if there is upfront visceral crisis or the patient is endocrine refractory? So what are the systemic therapy options for such patients? In the first line setting, we see that if the patient is germline BRCA mutant, then we may give PARP inhibitors, olaparib or talazoparib. If the patient is a HER2 low patients or ultra low, as I have discussed previously, the criteria for low and ultra low. So for such patients, we may give trastuzumab deruxtecan. And there is also the option of giving systemic chemotherapy. For the second line also, if HER2 low or ultra low, we may proceed with trastuzumab deruxtecan. If not, then we may give sacituzumab govitecan. It is a category 1 recommendation in this setting. And we may also give systemic therapy. Third line and beyond, we may use systemic therapy or biomarker-directed therapy. Now, the systemic therapy and biomarker-directed therapy regimens are the same as I have already discussed previously. These are the same regimens like anthracycline, taxanes, antimetabolites, etc., which are used in the TNBC setting, which are used in the hormone receptor positive setting. These are the same drugs. Now, coming to the diagram showing the mechanism of actions of the hormonal agents. Now, first I'm going to explain the estrogen receptor signaling pathway. That is, when an estrogen molecule binds to the estrogen receptor on the cell surface, this entire complex is internalized within the cell. It undergoes dimerization, then it is transported to the nucleus, where it binds to the response elements on the DNA, and where it leads to transcription and later translation. Also, there is some crosstalk between the growth factor receptor signaling and the estrogen receptor pathways. So these pathways of crosstalk may be either PI3K, AKT, mTOR pathway, or this may be RAS, RAP, MEK, that is a MAP kinase pathway. These ultimately lead to increase in cell growth, survival, and increase in angiogenesis. Also, the MAP kinase pathway stimulates the CDK4/6 and the cyclin D, leading to increased turnover of the cell cycle and thus leading to cell proliferation. So what do the aromatase inhibitors do? The aromatase inhibitors, you see, the source of estrogen in a postmenopausal woman is mainly the adrenal androgens, which get peripherally converted to estrogen. So aromatase inhibitors block this peripheral conversion. Now, how do the SERMs and the SERTs, that is the selective estrogen receptor modulators and degraders, how do these act? They act on the estrogen receptor by exerting antagonistic effects and sometimes degrading the receptors. Now, the PI3K inhibitors, what do? They inhibit the PI3K AKT mTOR pathway. The mTOR inhibitor everolimus, it also inhibits this pathway. And we also have the CDK4/6 inhibitors for hormone receptor positive disease, which also inhibits the CDK4/6 and hampers the progression of the cell cycle. First, I'll begin with tamoxifen, which is a selective estrogen receptor modulator. It is a non-steroidal anti-estrogen. It has agonistic effects on uterus, bones, and blood vessels, weak agonistic effects, and antagonistic effects on the breast cancer cells. Now, the tamoxifen-bound estrogen receptor dimer binds to the DNA sequences and inhibits the transcription and signal transduction pathways. Now, what is the dose of tamoxifen? It is 20 mg once daily. It has no relation with food. The tablets are available either as 10 mg tablets or as 20 mg tablets. And the indications, as I have already discussed, in the adjuvant setting, in the metastatic setting. Another indication is chemo prevention for patients who are at high risk of developing breast cancer, particularly BRCA mutant patients. So in such individuals, tamoxifen may be used as a form of chemo prevention. Now, coming to the drug interactions, since this drug is metabolized by the hepatic microsomal enzyme system, the blood levels alter when given along with CYP2D6 inhibitors or inducers. Tamoxifen in turn inhibits the hepatic P450 enzyme system and hence affects the action of the drugs metabolized by this pathway. So the common side effects of all the hormonal agents, which you have to remember, is the menopausal symptoms. So what are these? Hot flashes, vaginal dryness, and some discharge, mood swings, arthralgia, myalgia, and skin rash, etc. These are common to all the hormonal agents. Additionally, tamoxifen may cause fluid retention and peripheral edema in 30% cases. There is risk of thromboembolic events like DVT, pulmonary embolism, etc. It may cause hypertriglyceridemia. It may cause visual disturbances, cataracts, and retinopathy. And since it has agonistic effects on the endometrium, as we have read previously, it may lead to endometrial hyperplasia. However, the incidence of endometrial cancer with this drug is very rare. And next, we move on to the SERTs, that is the selective estrogen receptor degradation. Now, two drugs fall under this category. One is the fulvestrant, which is an injectable drug. Another is the elacestrant, which is an oral drug. So fulvestrant, we can see that it is a transparent liquid and may be available in vials of 250 mg or as prefilled syringe. And this elacestrant is an oral drug available in the tablet form, either as 345 mg tablets or as 86 mg tablets. Now, what is the mechanism of action of these drugs? These are potent selective estrogen receptor antagonist with affinity that is comparable to estradiol. They downregulate the ER expression, presumably through enhanced degradation. So both these drugs are approved in the metastatic setting. Now, the side effects and the dose. The dose I will discuss first. For fulvestrant, the dose is 500 mg IM on days 1, 15, and 29 of the first month. Following that, it is given monthly 500 mg IM. Elacestrant, the dose is 345 mg OD along with food. And as we can see that it is the metabolism is affected by CYP3A4 inducers and inhibitors. Now coming to the side effects that is common for all the hormonal agents, the menopausal symptoms, that is hot flashes, asthenia, arthralgia, myalgia, etc. In addition, fulvestrant may cause injection site pain and inflammation. There also may be mild headache and nausea. Then the next set of drugs, the aromatase inhibitors, they may be steroidal or non-steroidal. Exemestane is the steroidal aromatase inhibitor available as 25 mg tablets, and the non-steroidal AIs are letrozole and anastrozole. Letrozole is available as 2.5 mg tablets and anastrozole as 1 mg tablets. So these drugs also I have discussed here in a tabular form. So the dose of exemestane is 25 mg OD after food. That of letrozole is 2.5 mg OD with or without food. That of anastrozole is 1 mg OD with or without food. As we can see that once again, the side effects include the menopausal symptoms like the hot flashes, asthenia, vaginal dryness, mood swings, arthralgia, myalgia, etc. And since these are oral drugs, they also have some potential for nausea. So along with that, letrozole may additionally cause mild elevations in LFT and rarely some thromboembolic events. For anastrozole, there may be peripheral edema and some dry skin and scaly rash. Now, drug interactions, as we can see, that it is also the same. The drug levels are affected by CYP3A4 inhibitors and inducers. Letrozole, in turn, also inhibits the hepatic microsomal enzyme system, and thus it also affects the levels of the drugs which are metabolized by this system. Now, the CDK4/6 inhibitors. There are 3 CDK4/6 inhibitors approved in breast cancer. These are palbociclib, abemaciclib, and ribociclib. So palbociclib capsules are available as 120 at doses of 125 mg, 100 mg, and 75 mg. The abemaciclib tablets are available at a strength of 200 mg, 150 mg, 100 mg, and 50 mg. And the ribociclib tablets are available as 200 mg tablets only. So here I have put together these 3 drugs together once again. So we can see that only palbociclib is to be taken with food, and the remaining 2 CDK4/6 inhibitors have no relation with food intake. Palbociclib, the dose is 125 mg OD for 21 days and then 7 days off. For ribociclib, there are 2 different doses for the 2 different settings. Like for the adjuvant setting, the dose is 400 mg OD every 21 days with 7 days off. And for the metastatic setting, the dose is 600 mg OD for 21 days with 7 days off. For abemaciclib, if it is used as a combination therapy, that is with an endocrine therapy, then the dose is 150 mg BD. When it is used as a monotherapy, then it is given at a dose of 200 mg BD. Now, the side effects, we see that the common side effects of these drugs are myelosuppression, some GI toxicities, fatigue, etc. But the most notable toxicities I have highlighted here for palbociclib, the most notable toxicity is myelosuppression with mainly neutropenia. Additionally, it may also cause GI toxicities, fatigue, thromboembolic events, and alopecia. For ribociclib, the most notable toxicity is cardiotoxicity, that is QTc prolongation. Hence, it is to be avoided with other drugs causing QTc prolongation. It may also cause hepatotoxicity, GI toxicities, myelosuppression, and fatigue. Now, for abemaciclib, the most notable toxicity is diarrhea, that is GI toxicity. It may also cause nausea, vomiting, abdominal pain, transaminase elevation. Also, there is some risk of myelosuppression, fatigue, and thromboembolic events. Drug interactions for all 3 are with CYP3A4, inhibitors and inducers, since these drugs are metabolized by the hepatic microsomal enzyme systems. Then the next drug is everolimus, which is approved in the metastatic setting in combination with exemestane when the patient has progressed on a previous aromatase inhibitor. So what is this drug? It is an mTOR inhibitor, as we have seen the mechanism of action previously, that it inhibits the PI3K-AKT mTOR pathway. And the tablets are available in strengths of 10 mg, 7.5 mg, 5 mg, and 2.5 mg. The dose is 10 mg OD with or without food, and the common side effects are stomatitis, rash, diarrhea, anorexia, nausea, just for any oral drugs, and then fatigue, fever, cough, headache. So next up, PIK3CA inhibitors. Now, among the PIK3CA inhibitors, I will discuss alpelisib. It is given at a dose of 300 mg OD along with food. It is available in strength of 150 mg tablets or 200 mg and 50 mg tablets. The most notable toxicity is hyperglycemia, and the other toxicities, as you can see, are similar to other TKIs like papillopustular rash, pruritus, hypersensitivity, mucositis, diarrhea, nausea, vomiting, and there is also some risk of pneumonitis. Drug interactions, once again, CYP3A4 inhibitors and inducers, and this drug itself inhibits the hepatic microsomal enzyme system, and thereby it alters the levels of drugs which are metabolized by this system. Inavolisib is a comparatively new drug in this category, but since it is not available in India and it is a very new drug, so I'm not discussing this drug in details. Now we'll move on to the AKT inhibitor. So the AKT inhibitor that we were discussing previously, the one which is available is capivasertib. Now capivasertib is given at dose of 400 mg BD every 4 days of a week. That is, it is given for 4 days followed by 3 days off every week. The toxicity profile and drug interactions are similar to this PIK3CA inhibitors. So with that ends our discussion on hormonal therapy. So my take-home message for the students is that for breast cancer patients, you have to always watch out for cardiotoxicity, because anthracycline, trastuzumab, all these drugs are cardiotoxicity, and all these drugs cause cardiotoxicity, and not to mention ribociclib, the CDK4/6 inhibitor. It also has the potential for QTC prolongation, and also there is some risk of cardiotoxicity from chest wall or breast radiotherapy. So what are the points to be kept in mind before selecting any individual drug is that before selecting the drug, based on its toxicities, we should perform the relevant investigations to assess that the patient is fit for receiving this drug. Then we should take into consideration the patient's age, performance status, comorbidities, the side effect profile of the drugs, the logistic issues, and the patient's preference and support system is also be taken into account. So with that, I will end my presentation here. Thank you all for paying attention.
Yeah, thank you, Dr. Barnini Ghosh. So yeah, so I think it was a very, very interesting session, and I think it's a very vast topic, so not easy to cover in 1 hour. But I think it's a good overview of all the drugs which are used in breast cancer. So before we move on to the question answer, so for all the residents who are listening to this session, so there are 2-3 things which I want to just stress, which I think we should know as students. First is that make sure you see all these drugs during your residency. Many times what happens is we only know the theory, and the daycare the sister is mixing and administering the drugs, and you have not actually seen the drugs, and you clear your DM or DNB. So I would want you to ensure that you have seen / used / administered / mixed all these drugs and know how they are given. So one of my residents once, we were discussing, and he was saying ki what happens if Fesgo is given fast. I said it's not easy to give Fesgo fast. And when he actually went and gave Fesgo, he realized that why it's not easy to give Fesgo fast. Similarly, like fulvestrant. So you might think it's just an intramuscular injection. You can give it in the shoulder, but you have to give 2 injections of 5 ml each. That is why it is given in the buttocks. So there are a lot of fine points you will learn when you mix and use the drugs yourself. So as students of medical oncology, you should yourself make sure you see each of the drugs and how to administer them. Second is any oral drug, you should know the food interaction and how it is given. So many times, in a hurry, we just write the drug orally, but how the drug is to be administered is part of the prescription, and never write a oral cancer drug without mentioning how it is given. So you have to write the food interaction. When you write, you will learn, and you have to remember how it is given in relation to food. And you should have an idea of, anti-emetic and vesicant potential for each drug. So that is all part of practice. And even as chemotherapy goes down and new targeted therapy comes, this is not going to go away, because even, the new targeted therapies, they are highly vesicant and emetic targeted therapies. So you have to, be aware for each drug, how it is to be given, what set it is to be given, what is the vesical emetic potential, and it is part of, knowing how to use the drugs. So I'll just hand over next to the question and answer session. So let me introduce Dr. Senthil. So I don't need to introduce Dr. Senthil Rajappa. He is one of the most well-known medical oncologists and mentor to many people. And he is going to be the examiner for the Q&A session. And for the examinees, we have Dr. Pruthvi Patel, who is second year DNB resident from HCG Cancer Center, Vadodara, and Dr. Ketan Makwana, who is third year resident from Jawaharlal Nehru Cancer Hospital and Research Center, Bhopal. So let me hand over next to Dr. Senthil. Thank you.
Thank you, Vineet, and thanks, Dr. Barnini, for a very nice presentation. I learned quite a lot from your presentation. If I was to take a DM exam today or a DNB exam today, I'm very sure I will fail. So fortunately, I'm in a situation where I'm going to be asking questions and not needing to answer these questions. Himanshi, you will take control of these slides and keep moving them as we ask questions. What I would suggest is that let's not stick to what's just on the slide. We've got about 50 minutes to go. If anyone who's listening has got a question that you want to discuss or get answer for, which you have doubts regarding, then you can type it in the chat box. Either me, Dr. Vineet, or Barnini, one of us will definitely help you with the answer for that question, because we have a list of questions that we will go through. That's just to make the skeleton for this whole discussion. I don't want to repeat everything that Vineet actually said. He's absolutely right in every word that he uttered, that you need to know, see, feel, do, and so on and so forth. So this is how you will know your drugs. So let us start with this patient. So this is a patient who comes to you. This patient is being treated, obviously today we are discussing breast cancer. So this patient was treated for breast cancer and is coming back to you after a few days after her treatment with an arm like this. So what do you think is the diagnosis? What would have happened? How could this have been prevented? And how do you treat this condition is the list of questions that will come when somebody asks you a question with respect to the complication that you're seeing on your screen. So either Pruthvi or Ketan, I don't want to really call names.
Good afternoon, sir.
Yeah,
this image shows probably the extravasation injury caused by probably the anthracyclines. And if the patient will come with this or it happens during the chemotherapy, immediately I'll stop the infusion and stop the infusion and disconnect and leave the needle in the place. And I have to.
Ketan, let me interrupt you for a moment. So why did you say it's an anthracycline induced?
Probably, sir, because it is
doesn't matter here, right? So today, as I said, we are discussing breast cancer. So you said anthracycline. So can you tell me about the other drugs that are used and what is their potential to cause injury like what you're seeing?
Other drugs are all the vesicants are, sir, anthracyclines. In breast cancers are all anthracyclines and meclormithamine, even dectinomycin. And sir, vinca alkaloids are vinca alkaloids. We basically non-DNA binding agents are causing the.
So those are, so vincristine is typically not something that's used in breast cancer. So the other set of drugs are either a taxane or it is cyclophosphamide, right?
Even cyclophosphamide more than 1.5 gram per meter square.
That is right. Yeah. So you don't expect 1.5 gram, the total volume, to get into the hand, right? It's very, very uncommon for something like that to happen. So when somebody asks you a question saying, why do you say anthracycline? You say that the extent of damage that you're seeing, this vesicant damage that you're seeing, is very likely due to an anthracycline, because the other drugs that are routinely used in this setting are taxanes and cyclophosphamide, which are very unlikely to cause damage like this. I mean, you never know that this patient had extravasation, went home, and now there's a lot of cellulitis. She has come back. So, you can build up a story like that, but it's very likely anthracycline. Right. So let's say you are in the daycare when the sister calls you to say that some patient has had extravasation of anthracycline. What would you do?
Sir, immediately stop the infusion and leave the needle in place, identify this extravasation agent, and keeping the needle in the place, and I will try to gently aspirate as much as the solution possible, and will record it in the patient record, and then avoid any manual pressure over the area, and also mark the area of the extravasation. And then if the agent is anthracycline, then it will use the localize and neutralize protocol by applying the dry cold compresses every 20 minutes for 4 to 5 times a day. And also use the antidote, which is and a topical DMSO can be used, or dexamethasone can also be used.
So where in the hospital do you go and get DMSO, Ketan?
Probably, sir, in
Where do
skin
you get it?
department,
Which department?
dermatology department. Sir.
Dermatology department. You're working in a cancer hospital, let us say. Where
Yes.
will you find DMSO? I'm sure you've not done it. You've told me everything with the mistakes that have been written in the slide also. So it just means that you went through the slide that was sent to you. Never mind, it's all right. We are learning. Lovely. Karthik has written that it is in the Shubham and Karthik are absolutely right. You know, DMSO is used to do cryo of the stem cells.
Yes.
So all of them have shot. You know, it's all over the place. So DMSO is usually available. So I work in a cancer hospital. I don't work in a multi-speciality hospital. I don't even know whether dermatologists use DMSO, not to my knowledge at least. So you go to the blood bank, or you go to the BMT unit, and that's where you will find DMSO, because they use it along with albumin in order to cryo stem cells. So that's where you will get. The second mistake, which is there on the slide, and you also repeated it, is dextrosocane is not given as a topical. Dextrosocane is given IV.
Yes, sir, IV.
Correct. So on your slide, can I go to the next slide, Himanshi? Next slide. So on this slide, how to manage, okay, we started discussing that. Go to the next one. Next one, yes. So on this slide, you see that you keep the IV cannula, that's fine. You don't pull it off immediately. Aspirate as much as you can, give a cold compress, and then keep it elevated. How do you do dextrosocane? How do you do DMSO? Do you just pour DMSO on the hand, or how do you do DMSO over the extravasated area, Ketan? Or Pruthvi, if you know, you can tell me. You know, as I said, I'm not going to call names. You can just talk about it. If no DMSO, Anand, you just have to pray. What else can you do? I'll tell you what is to be done if DMSO is not available. I'll tell you. Prithvi, you can tell me. You're muted. Topically within. Yeah, go ahead.
If topical DMSO is not available, then
no, I'm asking you, how do you apply DMSO? Some people have said clockwise injection subcutaneous. It's already gone. Topical with insulin syringe. What do you usually do? Lovely. So Pragya Modak is probably the closest to the answer, or she is probably right. So what you generally do is you soak a gauze in DMSO and then apply it. There are some people who think 1 to 2 ml of DMSO sprayed over that area is also fine. So that is how you apply DMSO. So Pragya is absolutely correct that you soak it in gauze and then put it, because it depends upon the area it's extravasated, right? You can't go, injecting all over the place. That can be a challenge. So you use it usually over. Dextrosocane is given IV. Again, it's so administration of dextrosocane at the site of extravasation is wrong. Dextravasation is given intravenous 1,000 milligram per meter square day 1, D2, and 500 per meter square day 3. So that's how you do dextrosocane. Something that is not very prominent on this slide, but I think is very, very important, is call the plastic surgeon or the surgeon very early during the course of this management. Because if you don't get things done on time, then this is going to be a chronic ulcer. It's not going to heal at all. So I would suggest that you go for skin grafting as early as possible. That's a very important point in practice. Call the surgeon as early as you can. If both dextrosocane or DMSO is not available, then there's nothing like an antidote that you can use. So you just have to do the other things and then call the surgeon as early as you can. And then if you think that the wound is not healing or is not getting better, yes, debridement and grafting is what you should be doing. Sometimes you will need a flap to be transferred from somewhere, but all of these things are possible, and it needs to be very proactively managed. So that's what is important. Just to complete that cycle, Prithvi, I think you can't hear me, or okay, you cannot. So Ketan, you seem to be stuck
Sir.
with me for the next 15 minutes. Prithvi is not able to unmute.
Okay, sir.
Never mind, it's all right. Never
It's
mind,
okay.
it's all right. So that's something that's very important. Ketan, the other thing is, when will you use a warm compress? When will you use a cold compress?
Sir, in anthracyclines and anthracycline antibiotic, even alkylating agent, some of like maclormethamine, we'll use this hot dry cold compresses. And
Yeah.
in vinca alkaloids and plate and taxanes, we'll use dry warm compresses, sir.
Excellent, very good. So we will move on. That's about extravasation. So keep these points, at the back of your mind. Vincristine is the other. If you are working in pediatrics, vincristine is something that you will usually, if patient comes after a week, lovely question. So Ketan, answer that question. If patient comes after a week, do we still use DMSO or dextroxane?
No, sir, because dexazoxane has a role in the acute, immediate role is there, and DMSO also, I think it's a
So everything is in the acute phase.
acute role.
Right. So all these applied for a few days, 1 week, and all that is in the acute phase. If patient comes to you with this hand after a week, there's no point in putting anything there, because it's not going to help. Only your surgeon can help beyond that, and then of course God has to help you and the patient. So this can be a very nasty complication to get it. Next slide, please. How to prevent? That's very, very important. So tell me, Ketan, what can you do to prevent?
Sir, first of all, the IV
Next slide,
cannulation
Himanshu.
should be IV cannulation should be at the preferred site, avoiding at the joint site, and inform the patient whether he will feel any burning sensation or any irritating sensation after starting the drug, and also the free flow IV, free flow. The anthracycline should be given with free flowing IV cannula, and duration should be not longer.
So I think the best thing would be to use a port or a PICC line, isn't it, Ketan? So that's what nowadays we do, right? It's good. Yes, if you're in a resource constraint setting, your patient cannot afford and all those things, then every single thing that you said now applies. Where you put the cannula, put it in the, not on the palmar aspect, on the other aspect of the hand, and then use it in an area where the vein is good, it's prominent, there's not much subcutaneous tissue that is there, so that even if something extravasates, you're not going to damage much of the soft tissue underneath. Now, you want to be in a plane where you're not very close to the tendons and nerves and vessels, because if you end up damaging all of these, then the plastic surgery work that one needs to do is going to be even more difficult to do. So all these need to be kept in mind. Deepak wants to know, how long does DMSO need to be used? Ketan?
Sir, I have no
Okay,
idea.
maybe up to a week. Some people think even 10 days is fine, but the most important is that you use it early. I think that's the key to the whole thing. Himanshi, next slide, please. Okay, so all that Ketan just now said, rest local hydrocortisone, no, not to our knowledge, Naren. So we would not use local hydrocortisone to help as far as extravasation is concerned. Next slide, please. Okay, myelosuppressive potential of chemotherapy agents used in breast cancer. Move on, Himanshi. I think, Ketan, you can just read through. Himanshi, you can move to the next slide.
Those and all that.
Yes. So whenever you're looking at a set of drugs, think about it. Even if you don't know the answer, if you put in some logic, you will be able to come out with the answer. So think about it like this. Anything that's given dose then at a higher dose, more drugs will always produce more myelosuppression. So look at everything on the left of your screen. If it's dose dense, if it is TGH, if it is TAC, all of these are more likely to produce a higher probability of myelosuppression compared to if you just use 2 drugs or 1 drug once every 3 weeks and so on and so forth. So the ones on the left are high risk, the ones on the right are intermediate risk. Why is this important, Ketan? Why do we need to know this?
Sir, because for the growth factor and all prophylactically, whether we have to use or not,
So what is the indication to do prophylactic growth factors?
Sir, when the probability of developing the febrile neutropenia risk is more than 20%, that is at that prophylactic GCSF should be used. And if the patient is already had an episode of neutropenia in the previous cycle.
So suppose somebody has a episode of neutropenia in the previous cycle, why would you? All patients are
The
expected
febrile
to have some.
neutropenia.
Correct. So what are the indications for primary prophylaxis? You said if the incidence of febrile neutropenia is 10% or more, some people will say 20% or more, that's one. What other situations will you use primary prophylaxis?
Sir, in BMT setting is one.
No, I'm
in
talking about breast
those-
cancer. Let's not
Yes.
get to BMT setting.
Okay.
What other? So,
Sir,
so
dose
think
dense.
about
Sir,
what
dose dense. This
dose
rating
dense.
is.
Okay, dose dense we will anyway use. Very
Yeah.
good. What else?
And
Somebody
the
is saying old,
patient,
frail, malnourished. Okay.
Patient risk factors like old age, yes, age more than 65, and any and the also about means we have to see whether patient risk factor and the tumor risk factor and the drug risk factors, all that factors we have to consider.
Tumor risk factor, patient risk factor, right? So what is, let's say, what's the tumor risk factor that you will think of? Ketan, what
Yeah.
tumor risk factor are you thinking of when you say I want to use primary prophylaxis in that patient?
Sir, particularly in breast cancer, I think it is not being considered. But
okay, when would you consider it?
In sir leukemia and
so let's say somebody has come to you with stage 4 breast cancer with bone marrow metastasis. Is that a situation where you would like to use?
Yes, in that setting.
Government has already put it up there, extensive bone marrow involvement.
Yes.
High
Sir.
tumor burden and visceral crisis. Somebody who's had extensive radiation to the bone marrow already. Somebody who's old and frail. Somebody who's got so many comorbidities. Just think about it in your mind. Look at all situations where patients are more likely to get into trouble. That's when you would want to use primary prophylaxis. Secondary prophylaxis, very nice. Somebody has already put it up on the chat box. If there's already an incidence of febrile neutropenia, then you may want to use a PEG GCSF prophylaxis. Somebody had written PEG fill. So in the exam, again, very important, don't use brand names. Use pegylated GCSF 6 milligram 24 to 72 hours after the administration of chemotherapy. So that's how you will answer in the exam when somebody says what and how. Okay, so don't ever use brand names in the exam. You may use it in your clinic, you may use it in your hospital, that's fine, but not in the exam. Very good. Next slide, please. We have done this. Can we move on to the next slide? Move. Okay, so very nice question. Deepak, can PEG be given on the same day? Ketan, what do you think about it?
Post-radiation dermatitis.
Pardon me?
Usually avoid on the same day, sir.
Usually avoid, but the question is, can PEG be given on the same day? I think that's the question.
Radiation recall reaction.
No, we have not finished PEG GCSF at Pruthvi. Hang on. Somebody wants to know whether it can be given on the same day.
Yes, sir, can be given.
It can be given. Are there some clinical studies where it has been given?
No, sir, I'm not aware of that.
You are not aware of that. So there are some clinical studies where it has been given on the same day, but the convention is not to do. It can be given on the same day, especially these are some studies that have been done in the West based on which, their insurance is a problem, patients traveling back. It's not like our place where patients can just take it with some sister next to home or somebody can go home or administer and so on and so forth. So there have been situations where patients have been given PEG GCSF on the same day. Doesn't seem to be causing any additional myelosuppression because the problem with doing PEG GCSF on the same day, why is it that we are worried about doing it on the same day, Ketan? Or Pruthvi, can you tell me why is it a concern? Pruthvi?
Because, sir, more neutropenia happens, sir. Because
why would more neutropenia happen?
Because after GCSF administration, if marrow more produce the cells, then it comes out in the periphery, and if chemo is not wash out in 24 hours, so is more neutropenia.
Okay, so you're kind of telling me the answer, but not wording it appropriately. But I think your thought is correct. So when you're giving any form of GCSF, you're going to stimulate the stem cells, right? When you're stimulating the stem cells and giving chemotherapy at the same time, you're likely to injure the stem cells, and that's likely to produce more neutropenia than what you're giving it for, which is to bring down the likelihood of neutropenia. But this seems to be more a theoretical consideration. But in reality, it seems to be that it's not as we think, that stem cells are getting, they're proliferating and then there's more injury, because as I said, there have been some short, small studies where they have given PEG GCSF on the same day. There doesn't seem to be a high incidence of neutropenia. So to the answer that you asked on the chat box, can it be given on the same day, Deepak? The answer is yes. But how should it ideally be given? It is to be given usually 24 to 72 hours. Why is it started from day 3 to day 10 on the dose dense? Very good. So in the studies of PEG GCSF, what they have done is that they want at least a 2-week interval between the administration of PEG GCSF and the next chemotherapy regimen. So if you do chemo today and you're doing it on the 3rd day, let's say, then the time between the administration of pegylated GCSF and the next chemotherapy is less than 2 weeks. So that's the reason why in most dose-dense regimens, at least on protocols, they haven't used PEG GCSF. They have used GCSF in the fashion that you have just asked me on the chat box. That's day 3 to day 10. Let's say, for example, FOLFOX, for example, FLOT. Most of these, they would not have used PEG GCSF for this reason. So that's why in dose-dense regimens, in weekly regimens, you don't use PEG GCSF, but you use the conventional GCSF. On the same day, the chemotherapy will kill the augmented stem cells. So correct. So that's what we just said, Karan. So we said that, you don't want to push the cells up on one side and give the chemo on the other side, so that you will end up causing more marrow damage than what you actually want to do, which is less marrow damage or no marrow damage, and stimulate the cells coming up earlier. Okay, very good. So we will move on. We leave PEG GCSF and GCSF there. So what is this, Pruthvi?
So this is radiation recall reaction. So
very good. What's the relevance of this? Next slide, please.
So if a patient receiving adjuvant radiation, and then if any history of prior anthracycline based chemotherapy, so more chances of dermatitis happen. So
what's the relevance of this? Next slide. Himanshi, next slide. Why do you need to know this? Prithvi, why do you need to know this? So what would you think if somebody comes with a patch like this? It's a nice, well-defined patch here, but there are situations when patients that come with redness in the area that has already been radiated, or, the post-mastectomy area. What is your major concern, and why is it that you should know about radiation recall? And radiation recall is not specific to, just chemotherapeutic agents. It can be with antibiotics. It can be with many other non-cancer drugs also. Okay, Deepak says, to differentiate between, one of the things that you always want to think about is recurrence, right?
Yes.
So you see that Karthik has said the right thing to rule out skin recurrence. So if it is beautifully defined by a square area where you had radiation and you had an anthracycline, sometimes it can rarely occur with taxanes also, then you can reassure your patient saying that this is more likely to be radiation recall. Let's wait, just treat it symptomatically and see. While if it is not confined to that beautiful square area, then you're very worried that it may be skin recurrence. You may want to do a biopsy. So that is the relevance of knowing what radiation recurrence is, because this is a harmless condition. It will, in 99% of patients, it will just come and it will go away. So by looking at the anatomical extent on the skin, you can then decide whether it's recall or whether it's something else, some other skin problem. Or from our standpoint, more importantly, you should make sure it is not a recurrence. So that's the significance of knowing radiation recall. Very good. So next question, Himanshi. Emetogenic potential of chemotherapy drugs. So this is a very favorite question of all your examiners. So next slide. Go ahead, Ketan. let's do this.
Sir, the AC combination has a high risk of high emetogenesis potential, and
Okay.
carboplatin more than carboplatin UC more than 4, then doxorubicin more than 60 milligram per meter square, and epirubicin more than 90 milligram per meter square, according to the
Very good, very good. So all the other regimens that we use are moderately emetogenic.
moderate risk. Yes.
Very good. So tell me one antiemetic prophylaxis for highly emetogenic, one for moderately emetogenic. So what I would suggest both of you, Pruthvi and Ketan, and all the people who are listening, is this is a stock question in the exam. So just by heart one antiemetic regimen that you are confident about, you know how to give, and tell that in the exam. So Ketan, you will tell me for highly emetogenic. Prithvi, you will tell me for moderately emetogenic. Ketan, you can start.
Sir, for highly emetogenic, I will use 4-drug combination, which will
Excellent.
include the 5T3 receptor, NK1 receptor,
So
and
I want you to write a prescription, Ketan.
Okay.
I want you to say X drug at X dose, intravenous, whatever. Tell me
Okay,
that.
sir. For capsule apricap 125 milligram.
Again, don't use apricap. Apricap is
Sorry,
branded.
capsule apripitant
Right.
125 milligram orally on day 1, and then 80 milligram day 2 and day 3.
Very
and
good.
injection dexamethasone 8 milligram and plus injection ondansetron 8 milligram in 100 ml NS IV over 30 minutes, and olanzapine 10 milligram oral tablet on the day 1. Then for day 2 and day 3, I'll use dexamethasone and olanzapine for day 2, 3, 4.
Okay. So what are the mistakes that Ketan did, Prithvi?
Sir, in highly metogenic drug, there's 4-drug combination.
No, I want you to only tell me, did Ketan say everything right? He was almost right. He is 99% right. Just small changes. Deepak says high R50, D8, G3. Interesting. We'll come back. I can't understand what's R50 and G3. Never mind. So there are two things, Ketan. So one is the dose of olanzapine. Olanzapine is not given in 10 milligram. Yes, 5 milligram, as Karthik said. Even with 5 milligrams, you see that a lot of our patients actually doze off. So we generally use 2.5 milligrams. So Isha is absolutely right. Though all of us in convention end up using 8 milligrams of dexamethasone because our dexamethasone strength comes, if you really look at the book, it will say 12 milligrams of dexamethasone, but it's okay. So these are the two different. Shubham has, rightly said they're 12 milligrams. So by book, it's 8 milligram ondansetron or 0.25 milligrams of palanositron. Then you have apripitant at 150, 80, 80, and then you have olanzapine, 5 milligram at bedtime, day 1, day 2, day 3, day 4, day 5, and of course dexamethasone that we already discussed. So these are the 4 drug combinations that you took, correct? Okay, very good question. MS, whoever that is asking whether dexamethasone needs to be reduced along with apripitant. So why is MS asking this question, Prithvi? Can you tell me the answer? MS is asking a very, very important, intelligent question. So the reason he or she is asking that question is because we know that apripitant increases the serum levels of dexamethasone. So that's why there is a recommendation to bring down the dose by 50 milligram, but that's not something that routinely we follow, and that's why some people are actually moving to a steroid-free antiemetic regimen now. There's a nice study. So again, you should know this study from India. Venkatraman Radhakrishnan from Cancer Institute has done a nice randomized study of a dexamethasone-free regimen. So please go and read that because it's an Indian study. Examiners are very, very focused upon asking Indian studies because it is Indian patients, Indian data. So it's much more authentic to use in our patients. So Venkatraman Radhakrishnan, a good friend of mine from Cancer Institute, has done a brilliant study published in the Journal of Clinical Oncology. So go and look at that. He talks very nicely about why dexamethasone can probably be given up when you're using these set of drugs. So very good question. Very nice point made. So what about moderately emetogenic? You just use a 3-drug regimen if it's moderately emetogenic. Yeah. So there is this new drug called Nutipitant. What is that, Ketan?
That is a combination of this palonosetron and
Netopitant, sir.
Yes.
netopitant and
So is that better compared to
that
aprepitant or fosaprepitant and dexamethasone ondansetron combination?
yes, sir, that was compared. The study was there, and it was better in preventing
In
the
terms of what was it better, Ketan?
side effect profile, sir.
Was
And
the side effect profile better, or was it better in terms of some of the antiemetic properties? Long half-life, lovely. Pradnya Modak has again answered saying, in general, the incidence of vomiting was lesser. The likelihood of having delayed emesis was much lesser when you used a combination of palonosetron and nitipitant, which now comes as a tablet kit, which you use just before patients are administered chemotherapy. So that's what most of us have moved to now. So remember all of these things, dexamethasone dose, olanzapine dose, whether you need to cut down on the dose of dexamethasone, and then what's the role of nitipitant. These are the things that you need to. So for me, as I started by saying, just learn one regimen nicely, by heart it, so that even in the middle of the night, you're woken up and asked this question, you will answer. And just go and vomit it in the exam. Vomit antiemetic prophylaxis. So that's what you should be doing in the exam. Next slide, please. Okay, here, whatever all of us discussed in the past 2-3 minutes is here on your screen. So it's 4 drugs for high risk. 3 drugs are also a possibility. 3 drugs with and without, all these that are there on your screen. For moderate risk, 2 drug regimens are also fine, but some people tend to use 3 drug regimens if there is the likelihood of delayed emesis is high, especially olanzapine is a very good drug that we're using now for delayed emesis. You'll get all these slides. You don't have to copy any of these. I'm sure, they should be accessible to all of you. Next one. Okay, define primary and secondary resistance to hormonal therapy. Go ahead. Pruthvi, go ahead. Next slide, please.
Yes, in primary endocrine resistance, it's called as relapse in within the 2 years of adjuvant therapy, and in the metastatic setting is the less than 6 months recurrence, less than 6 months progression in the first line endocrine therapy. And in the secondary resistance, it's defined as the relapse while on adjuvant therapy after first 2 years of endocrine, and or the relapse within 12 months, or in the metastatic setting, disease progression after 6 months of endocrine therapy.
Ketan, why is it all these definitions are important? Why do we have to break our head?
sir, because we need to see whether upfront like in primary endocrine resistance, the patient is not responding, whether we have to see whether any other mutation is there. Where
you won't see it if it is secondary resistance?
Yeah, in secondary
You'll
also
see.
we'll check.
Correct. So then why do you need to know? Not sure.
No. Yeah, and also
Pushpendra has written something. So read what Pushpendra has written. No re-challenge. I don't think we do re-challenge with SERDs anymore, right? So he has said something very important.
This is morphology. This is property has been changed or not. We have to see.
So to know disease biology, more importantly is the second half of his sentence, which says likelihood of response to second line endocrine therapy.
Yes.
Okay. So let us say your patient took tamoxifen or let's say letrozole, and you saw that the disease came back. It's all over the place in 6 months.
Yes.
Okay. So you did surgery, you did chemotherapy, did all that we generally do for patients, when they're treated for localized breast cancer. And this patient comes within 6 months with disease that's come back. And there's disease in the liver, there's disease in the bone, there's disease in the lung. You rebiopsied, and the estrogen receptor status went down from 50% to 30%. The progesterone receptor was 40% earlier, it went down to 0. In this patient, I'm very nervous to use endocrine therapy again. You can say do PIK3CA, induce fulvestrant plus alpelisib, or things like that. But for me, I'm very nervous because in a patient who's got extensive disease and seems to be primarily resistant to endocrine therapy, I will be very nervous in order to use another endocrine therapy, especially if it is single agent. Here is a situation where in ER positive breast cancer, I may want to jump to chemotherapy a little early, or I may want to use something like trastuzumab deruxtecan, especially if your patient is HER2 low in this particular situation. Okay, so this clearly tells you about disease biology, because there may be some mutations that are there inherently in this disease, which is making it resistant to endocrine therapy. The relevance of this is that you may want to do a second-line endocrine therapy along with a targeted therapy that can overcome this resistance mechanism, or you may want to leave all of this and jump very early to chemotherapy, because even though this is expressing ER, the biology is in such a way that it is not responsive to an ER targeted therapy. So this is very, very important. That's why we are putting this into, you remember, you have to understand that these numbers are very arbitrary. What happens if somebody relapses in the 13th month? What happens if somebody relapses in the 10th month? It's not very different from the 12th month, right? It's like saying platinum resistance. 6 months is platinum resistance. What happens if somebody gets disease back in the 7th month versus 5th month? Okay, so remember that these are continuums, and we are drawing a line there so that clinical trial inclusion is also uniform. You know, if the patient didn't get ticket to come and see you and then came 15 days later, that can change the biology from resistant to sensitive. No, that's not the way it is. You have to understand that these cutoffs are arbitrary based on some retrospective data, and these are continuous variables, and you have to interpret it in the total context. Let us say the same situation, somebody has progression with just 3 bone metastases. Okay, the first situation I gave, I said there was disease extensively in the liver, I said there was disease in the lung, and then there was disease in the bone. I am very nervous to use second-line endocrine therapy. Let's say the same patient came with just 3 bone metastases on the PET CT scan. You are in no hurry to get a response. That lady is, let's say, 75-year-old, not the best candidate for another line of chemotherapy. You may still want to do a second-line, endocrine therapy with a, with fulvestrant, or if you can lay your hands on a SERD, plus minus another targeted therapy, because there you can wait. You can see whether the response is coming on or not. You can wait for 6 weeks. You can wait for 3 months. But if you have a lot of disease there, you may not want to do something. Okay, so you have to interpret resistance in the context of the patient, not only based on these definitions, because these are arbitrary cutoffs. Pushpendra says, sir, is the endocrine refractory mean something like progression even before the mentioned time point of primary resistance? Yes, primary resistance is also generally interchangeably used with refractory. That you started a therapy and there was absolutely no response. The slightly different situations, you started a therapy, there was response in the first scan, but progressed within 6 months. Both of these are generally taken as refractoriness. That means absolute lack of any response, though the first situation is a little different from the second situation. So they are interchangeably used most of the time. Okay, so this is the relevance of what primary and secondary endocrine resistance are. In the secondary, you're willing to go a little longer, try another line of endocrine therapy. In primary resistance, you're a little nervous. You don't want to do it unless time is on your side. The disease volume is less, and you can do some endocrine therapy to see whether these patients are likely to respond or not. So that's the relevance. Next slide. Okay, the difference in cardiotoxicity caused by anthracyclines versus trastuzumab. Next slide, please. Pruthvi, go ahead.
Yes, sir. There is two types of cardiotoxicity. Is a type 1 and type 2 toxicity. Type 1 is anthracycline induced and type 2 is trastuzumab induced. Generally, anthracycline induced toxicities are generally irreversible, where trastuzumab induced were reversible. And anthracycline toxicity as dose dependent, where trastuzumab induced cardiotoxicity no dose dependent, and structural changes present in the anthracycline induced cardiotoxicity, where trastuzumab induced cardiotoxicity no any structural is a cellular dysfunction, and on the biopsy is a no any show any tissue damage. And anthracycline induced toxicity can be acute or can be delayed, and in the trastuzumab induced toxicity appeared may be delayed.
Okay, so how do you minimize anthracycline induced cardiotoxicity?
Under first of all baseline cardiac function noted,
Very
and
good.
yeah, and after starting of anthracycline, if a baseline cardiac function more than 45%, then we when cumulative dose we reached approx 300 mg, we repeat the 2D echo, and if baseline cardiac function is less than 45%, we monitor the cardiac function every each cycles. If cardiac function drop by more than
So Prithvi, let us just hold on for a
okay.
moment.
Okay,
So
sir.
we said type 1 anthracycline induced. When do you generally see cardiotoxicity?
Is sir
Okay, today
if
you're
prior
treating this
history of
patient. No, today you're treating this patient. You finished, or rather you're starting today. Does the cardiotoxicity come in 3 months, 6 months, or it comes a little later?
sir comes a little later.
Correct. So it comes a little later. So this eco monitoring and all this will not get you anywhere because it comes late. So
Late.
your 3-month eco is good. So first of all, we would be very apprehensive or not use any anthracycline in a patient who's got an ejection fraction of less than 50
Late.
itself. You said 45, okay, we'll give it to you. It doesn't matter 5% this way, that way. But the point is that you should avoid using anthracycline in a patient like that. There's nothing like monthly monitoring. Okay.
Okay, sir.
You will create damage that will manifest 6 months after the patient goes home, not when you're treating. So that's one. So if you have the option of using a slower infusion, then that brings down, because the incidence of cardiotoxicity is related to the peak drug that is reached. Okay. So
Okay,
if you do a slow infusion, you're likely to be less. A liposomal preparation is also likely to bring down the incidence of cardiotoxicity. How do you use this dextroxoxane? When do you start dextroxoxane?
I think so.
So let's say this is a rare situation in adults. It's most common in pediatrics where you want to do retreatment with an anthracycline. So let's say you said 300 per meter square is the cumulative dose that you want to use. So the moment you reach 300, you start dextroxoxane along with the anthracycline from then on. Okay.
Okay, sir.
Ratio is 1:10, 30 minutes prior is in terms of the way you give it, but you need to start early. It is not after, it is not it's a cardioprotector. It does not reverse cardiotoxicity. Please remember this.
Okay,
So
sir.
when you're going to exceed, you start along with the chemo. Nothing really reverses anthracycline-induced cardiotoxicity. So that's the way. Yes. So before doxorubicin, obviously, when you're infusing it, you give this first because you want to minimize iron-induced free radical or iron-dependent free radical injury. So you need to obviously give it before. So give it before when you want to exceed the dose cumulatively, not after the cardiotoxicity happens, because it's going to do nothing to the cardiotoxicity at all. So this is very important to keep in mind. Statins can be given with anthracycline, it's up to you, but it's got nothing to do with the cardiotoxicity incidence. It doesn't minimize it, nor does it reverse it. Trastuzumab again is the same. 90% of trastuzumab-induced cardiotoxicity is reversible. It is not 100%. So one cannot say it is always reversible. As rightly put on this slide, it is often reversible, not always reversible. So these are broadly the differences between anthracycline and trastuzumab-induced cardiotoxicity. Very good. Can we go to the next slide, please? How to prescribe aromatase inhibitors? Very good. Ketan, next slide, please.
Yes, sir. Means according means we have to tell the patients the potential side effect of the drugs like this osteoporosis, and also we have to.
So what is the most common side effect that you see, or rather the most common side effects that you will see with an aromatase inhibitor?
Sir, arthralgias.
Arthralgia is very good. What is it that they typically come and complain to you?
Bony pain and fatigue.
I don't know what AIMSS is. So all people seem to be typing AIMS and AIMSS, whatever it is. So you tell me, Ketan, what is it that patients will generally, they will say joint pains, body pains. Of course, that's one. What else do they say? Early morning small joint stiffness is very common and very typical of letrozole-induced musculoskeletal symptoms. Okay, so small joints rather than large joints. As soon as you get up in the morning, they feel stiff. Of course, AI-induced musculoskeletal symptoms. Okay, very good. So that's an abbreviation for that. I didn't know that. Excellent. So that's what most patients will complain of. Apart from that, hot flushes and all the other problems that Barnini very nicely listed in her slide when she was presenting. Excellent. So what is this DEXA scan? How does the report of a
Bone
DEXA
mineral
scan
density
come?
basically we check, sir.
Okay. So why do you want to check that?
Because of the risk of, sir, osteoporosis is there with the AI. So
What happens if there is osteoporosis? It doesn't matter. Let it happen. Anyway, postmenopausal osteoporosis is going to happen.
possibilities of the fractures are increased.
So osteoporosis and fractures are very important to prevent. So what do you do? What is the report of your DEXA scan? How does it come as T-score?
Yes, sir. T-score, yes, sir.
What is this T-score? They give you a T-score, they give you a Z-score. No?
Yes, sir.
So what does it mean?
Sir, at this moment, I don't.
At this moment, you don't know. Okay, you should go back and see. It's the average for, Z-score is average for that age and sex. It's a standard deviation, correct? So T-score is usually matched to somebody at 30 years. Your score, standard deviation in either side is what? So if it says, somebody says minus 2.5, so you usually grade, let's say you draw a line in the center and then you say minus 1, 2.5, more than minus 2.5. And then there is plus. Scores are usually very uncommon. It is usually minus. So anything between minus 1.5 and 2.5 is osteopenia. Anything more than minus 2.5, let's say minus 2.7, that is usually osteoporosis. Okay. So you should know how to read that report. You will usually ask for the hip. Fine, they will do for the whole body. But what we routinely ask for is somebody, okay, Savine says it's 1 to 2.5, some is 1.5 to 2.5. It's okay. So what is important to understand is that anything, so that's the standard deviation from the normal expected for a 30-year-old lady in that bone area. So a 30-year-old lady in that bone area, what's the density? What's the density of this lady expressed as a standard deviation on either side is what you get as a T-score. Z-score is age-matched, sex-matched, okay?
Yes.
So all patients should go on bisphosphonates if you're using an aromatase inhibitor or if you're using a GnRH analog, right? So what are I think that's the next question. Go to the next question, please. Okay, so what bisphosphonates are used? What are the doses that are used, Pruthvi? Pruthvi, what bisphosphonates? Go ahead. Okay, Ketan, what bisphosphonates, what are the doses?
Bisphosphonates, sir, we usually use zoledronic acid 4 milligram and for pamidronate 60 milligram we usually use.
Pamidronate, okay. What are the ASCO recommendations for use of bisphosphonates? What are the ones that ASCO typically recommend? Pamidronate is, to my knowledge, not
yes, sir.
available.
Zoledronic acid is more commonly used or recommended agent, and that is also 12 weekly.
12 weekly. So
that was the trial was compared for weekly, monthly, and 3 monthly, but the results were not the 12 monthly.
So we are now discussing a slightly different situation, isn't it, Ketan? So we are discussing adjuvant letrozole and then bisphosphonates along with adjuvant letrozole. We are not discussing metastatic disease 1 month versus 3 months. So here, isn't it given once every 6 months for 2 to 3 years?
Yes, sir. Yeah.
So there's a lot of difference between this. Okay.
Yeah.
So somebody, Savine has said zoledronic acid, ibandronate, clodronate. So Savine is correct. So zoledronic acid is 4 milligrams once every 6 months or 3 years. Yes. Ibandronate is a tablet, clodronate is a tablet that's taken every day. So these are the choices. So they will ask you, renal and zoledronic acid, osteonecrosis of jaw and zoledronic acid. So you should be thorough with that, When does it occur? Is it a dose-dependent toxicity? How do you make a diagnosis of osteonecrosis of jaw? What is the dose adjustment of zoledronic acid for, creatinine clearance of, let's say, more than 60, less than 60, 30 to 60, whatever it is. So these are things that are very important for the exam, because these are very relevant when you're handling these drugs in your patient. So go back and read that. We don't have time really to go through each one of them. What is this? Identify the condition and the offending drug. Next slide, please.
So it's probably due to, yes, docetaxel serpentine hyperpigmentation. Yes.
Correct. So serpentine, I didn't know about this, that this is called serpentine supravenous hyperpigmentation. I'm hearing about this for the first time. Anyway, never mind. It's good to know. 5FU is right. In the breast cancer setting, docetaxel, Karthik, tattooing, you must be a fashionable guy, I suppose. Nobody likes to tattoo the way it is. But never mind. Serpentine supravenous hyperpigmentation. That's just a clinical curiosity, I suppose. The next slide, please. Okay, tell me the key toxicities of alpelisib, and then we'll go to how to prevent it.
Sir, key toxicity is hyperglycemia.
Excellent.
So there is hepatotoxicity is also there, and diarrhea. Yes.
Hepatotoxicity. So remember, there are three toxicities, Ketan. One is diarrhea, one is skin toxicity, the other is sugar going up, right? When do these toxicities actually occur? That's very important for you to keep a watch on these toxicities, right?
Yes, sir.
When do these actually happen?
Sir,
so when does elevation of sugar, diarrhea plus minus mucositis, when does it happen? So it is very important always to know.
We have to,
yeah, go ahead.
We have to see whether the patient is having already any pre-existing diabetes is there or not, or any family history is there or not.
So you first check the
HbA1c,
monitor, right?
Yeah, and monitor the blood glucose baseline.
Okay, so you screen for patients not using blood glucose. You usually screen for patients using the HbA1c. Okay.
Okay.
Generally, any HbA1c that's elevated, there are various cutoffs, clinical trial cutoffs versus clinic cutoffs. The clinical trial cutoff is between, it's usually anything more than 5.4. They have not taken or enrolled in successive studies. In the first study they did, but after that they stopped enrolling these patients because the incidence of hyperglycemia was very high and patients started getting into trouble. So you do the HbA1c, make sure that the sugar is under control, and then enroll, when you're starting. What drugs do you use if somebody has got hyperglycemia because of alpelisib?
Metformin.
Go ahead, tell me.
Metformin, sir.
Exactly. So you don't use insulin because it is an insulin resistant state. So you use metformin or one of those SGLT3 inhibitors, or some of those drugs are what are generally used unless somebody is in the ICU with a sugar of 600, 700 and ketosis and stuff like that, where insulin is routinely used. Otherwise, in the clinic, when patients are started, some people even prophylactically start metformin for these patients. Diarrhea usually happens in the third month, fourth month period during the 120 days period. So it's a late complication. It does not happen early. Skin and mucositis can happen early. There are some studies of antihistaminics used prophylactically for these patients. There seems to be a low incidence of skin toxicities. Similarly, for mucositis, as a preventive measure, you proactively start dexamethasone rinses early. So that's also been shown to bring down the incidence of, that's also been shown to bring down the incidence of these toxicities. So why is it important to know the timelines? Because you need to look for it at that time. Very early in the second, third week, you will find that the sugar will spike up. You will find that if there is a skin rash, it happens usually in the first 4 weeks. That's the median time to occurrence of this particular complication. So if you know the median time, then you will be able to spot it and treat it up. I'm sure last week, Ullas beautifully must have discussed about lorlatinib and the various timelines of all the side effects of lorlatinib. When does hyperlipidemia occur? When does the CNS side effect occur? When does edema occur? When does weight gain occur? You should know when all these occur so that you can appropriately counsel your patients first, most importantly, and then act upon these side effects whenever they happen. So that's why you should know. Can we move to the next one, please? Next one, please. Okay, so this is more a theoretical question. Can chemo and endocrine therapy be given together? I think the answer is ideally a no. But
No.
today we give TDM1 along with endocrine therapy. We do TDXD along with endocrine therapy, right? So I think it's more a from an exam standpoint, the answer should be no. But in reality, we are slowly moving towards it's okay to do. Next slide, please. Himanshi, next slide. Next one. Okay, so next slide, please. What's the difference between topoisomerase and alkylator induced? Next one, Ketan, we can just read through. I think we are running
Yes,
out of
sir.
time.
Topoisomerase usually, sir, has a latency period of 1-2 years, and alkylating agent has 4 to 7 years. And so there are some particular cytogenic differences, like topoisomerase is 11q, and alkylating agent is monosomy 5 or 7. And in topoisomerase, there is no MDS phase before developing the AML. But in
Very good.
alkylator agent, the MDS phase is there, sir.
Okay, right. Excellent. So these are some of the differences. Himanshi, next slide and the next slide. So these are some differences that one needs to know. Some of your examiners are very interested in asking these differences because prognostically an alkylator induced one is poorer because of all that you're seeing on your screen, while a topoisomerase induced leukemia, not that it's got super prognosis, is better than the alkylator induced one. But most of the time they do poorly and they end up needing a bone marrow transplantation or a stem cell transplantation. Next slide, please. Which drugs used in breast cancer are permitted during pregnancy? Next slide.
Sir, usually, sir, we avoid chemotherapy in the first trimester of pregnancy. And in second or third trimester, AC combination can be given, and all these anti-HER2 therapy should not be given. And there are some trial of using single agent paclitaxel also, but towards the third trimester.
Excellent. So nothing in the first trimester. That's the simplest answer. There's very little data for any of the targeted therapies. That's means trastuzumab, pertuzumab, and all of them. Taxane has got slightly better data. The best data is for anthracycline, cyclophosphamide. So second trimester, third trimester, that's when you will use. So that's a simple, easy way of looking at it. You're absolutely right, Ketan. Next slide, please. And the next slide, please. Oh, lovely. So we are done. So looks like it. Very good. So I think, okay, no hormonal therapy, Avinash, absolutely correct. Very good point. No hormonal therapy at all. So I think we've just sampled a few questions. These are very common questions that come in your exam, but I think there's no end to what you need to know and the kind of questions that will be asked. Very important to understand is that you should make sure that you are taking the examiner in the pathway that you want. You're not letting them drag you into a trap. So if you give a complete answer rather than a half-hearted, incomplete answer, it always becomes easy to get through the exam because then you're not only telling the examiner that you're aware and you know about it, you're also taking the examiner into a pathway that you are very confident about. Be confident. Stock questions need stock answers. You don't go there, sit down and start thinking about what the answer should be. Make sure you're going through this repeatedly with your friends. Let your friend ask you a question like what we did today, and then answer to your friend. Then you ask a question to your friend and your friend answers. Look for mistakes, correct it so that it becomes easy when you go to the exam. And I'm sure all of you will do superbly well and come out with flying colors. You did very well, Ketan. Pruthvi, unfortunately, your mic was on and off. Your connectivity doesn't seem to be at its best. Never mind, that's all right. Maybe some other time you will get a chance to, talk and answer more questions. Thanks so much, guys, for giving me this opportunity. Whether you guys learned or not, I certainly learned from Barnini's presentation and this interaction and many of those things that came up on the chat box. I hope you found it useful. Back to Karan or Barnini or
Thank you, sir. Thank you very much.
Thank you, sir.
Sir. Thank you, Senthil, sir, for your insightful discussion. It was very useful. I'm sure all the students would have carried a lot of messages and also regarding exams, how to answer, and everything was really very well organized. And I also thank Dr. Barnini for her extensive presentation, which has eased the whole discussion. So next week we are going to discuss yet another series on drugs in biliary tract cancers and neuroendocrine tumors. I hope all of you will join for this discussion. Thank you very much for the organizers to give all of us this opportunity. Thank you very much.
Thank you. Bye-bye and good luck.
Thank you. Goodbye.